Oh, hey, Chris.
Hey Chuck, how are you?
I am better than you this morning, I think.
Yeah, it's been a rough one. Recovering from a cold and also recovering from call. So two things that start with C that are interfering with my life, and now we've got a third with Chuck. But who loves that alliteration? But yeah, got beat up a little bit on call last night. But I'm happy that we're here together.
Yeah, that is tough. Call is, I generally don't mind it while I'm doing it, but as one ages, Chris, it doesn't get any easier.
You'll have to tell me about that one day. I'm not sure what that feels like. I was telling our fellow Dan Hong that I used to like taking call with him, but now I'm not sure. Clearly is making me change my mind. Still a good guy, but he does like his podcast mentioned, so I did mention to him that I would shout him out again.
I had a good
Apparently, he
con
gets a lot of texts saying that he's famous when this happens.
Oh Lord. Well, he and I have worked together a little bit, not formally on service. It's been fun. And I had spoke to our previous resident, Liz Grasser, who's out of Utah, and she also seems to have developed a black cloud reputation. But she said the right thing. She goes, I think I'm a black cloud, which my attendings don't like, but you kind of sort of want that as a fellow.
You got a year to learn, right? So you got to get it all done. I mean, you look at as a fellowship director, I study people's case logs.
Nice.
And you see that some people get a lot of cases, other people don't. It's been pretty uniform this year. But yeah, I think there's just stuff that comes in unplanned that you got to take advantage of.
Absolutely. And yeah, it's been, the fellows are always part of the joy of call, part of the pain of call. And it's all sometimes it gets mixed as one into my head, fellows, pain, call. But
Let me give
that's
you a
not
little
totally
let me
fair.
give you a little perspective. It's a hell of a lot better than not having a fellow with you on call. So let's just put it that way.
There is no doubt that is very important truth.
Funny story about Liz and Dan is that when we were at the Hand Society in Minneapolis this year, it was the end of Dan's rotation with me. He had spent his first, I guess we split it up, so he did 6 weeks with me or something like that.
Yeah.
And I was very excited. I said, Dan, we're both getting on a Monday night at the Hand Society. Why don't we go get dinner? We're on the same flight. Let's go have a post-rotation recap, a little bonding time at dinner, and
I know it's coming.
set up a reservation. It was great. I was super excited. It was late, so if it was anybody else, I would have said, "Nah, I'm not really interested. I'm just gonna go to bed." So he's like, "Yeah, sounds good." And he's like, "Do you mind if Liz Grasser comes?" I said, "I love Liz. Liz is great. Sure." She's already eaten. She's not gonna eat. I was like, as somebody who kind of knows a little bit about restaurants and restaurant business, like they're not gonna like that. But of course, that'd be great if Liz could come. I would love to see Liz. So Liz crashed our mandate, and it was lovely to see Liz. She had a cocktail, had some dessert, watched Dan and I, mainly me, eat excessively.
That is hilarious. And Dan's connected in the restaurant world in St. Louis. I
Yes,
didn't
he is.
know. He shared with me his connection with, I'm going to get the name wrong, Mr. Bogner, who has the really delicious sushi restaurants and has opened a third, is opening a third. Did I get the name wrong?
Celebrated chef, Midwest and perhaps nationally. Great place. So Dan, Merry Christmas, Happy New Year. You've gotten your unsolicited 4 minutes of airtime on our discussion, so we have to get rolling on the actual topic today.
Yes, we do.
Before we
Yeah.
do that, we should thank our sponsors at PracticeLink, and I'm going to read the copy this time. So the Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/ the upper hand.
Now we got a really cool email about some advocacy topics, which is something that doesn't really come up very often, I think, for most practicing surgeons and therapists. But it does affect our lives on a daily basis. And before we jump into that great email, I hear you have an interesting elbow case that you wanted to discuss.
Yeah, I've talked about pediatric and adolescent elbow on this call. And for those who hadn't heard discussions. I think first of all, it's a good example of recognizing opportunities when they are presented to you. Elbow in general was not something I planned to focus on, but increasingly, those challenging pediatric and adolescent elbows have become a part of my practice. And you may have always planned since you were 3 years old to take care of patients with nerve injuries, maybe, but elbow to me is not like that.
We told this I can, I've talked in many venues and I cannot remember, as you have, when I've told what stories, but have we talked about how I got into the nerve practice at WashU?
If we have, my senior status is showing because I do not remember.
Maybe a topic for another day, but I was definitely voluntold and it worked pretty well, but I was voluntold by one of our partners that that was what I was going to do. So good match.
Oh.
Of course he knew it was going to work. So it was good.
It's nice when people have that foresight before us. But what's interesting about pediatric elbow, and maybe I would say pediatric is less than 12. Someone may write in and tell me I got the definitions wrong. But so much of the elbow is cartilage that when you have a distal humerus or proximal radius or ulnar injury, it can be hard to pick up radiographically. I think we all know that. You're looking for fat pad signs where the x-rays show a little dark around the bones, which is fluid, um, where an anterior fat pad sign is okay, but a posterior is not. But the message is that x-rays don't always tell the tale. Would you agree with that?
I agree with that. I remember being tortured on the peds service as a resident, trying to analyze these elbow x-rays of adolescents and kids. I have peds really, and always struggling. I mean, has anything changed since many, many years ago when I was in training about how to think about radiographically? Have any of those findings changed? Clearly the x-ray technology itself hasn't changed, but do you jump to other types of imaging earlier?
I think, well, yes, I think we do. And I would say to start, you have to know the basics, you have to know what you generally should be looking for, but there is never shame in getting the contralateral elbow. And I've been doing this a long time. I get contralateral x-rays all the time, really helpful. But not always, they don't always tell the tale. So your point is good. I mean, a CT or CT angio, which it was ordered in this particular case, I'm sorry, not CT angio, CT arthrogram. But for me, it's usually an MRI, which I think gives us what we need to know. Um, Briefly, this case was of a child who had a shear injury of the trochlea and capitellum, which was incredibly subtle on X-ray, where there's just a sliver of bone that you couldn't really see, could see maybe, and ultimately a CT scan was ordered. It did show there was something going on, so we did. So this is a young patient, maybe 10 years of age, and we did an elbow arthroscopy to better understand the problem, which thankfully I feel comfortable with now. But scoping a kid where the safety margins are small, it's always a little hairy. Um, and then we ended up opening and fixing just an unbelievably distal shear injury with just a tiny bit of bone. Ultimately, was great, but tricky case, and again, gets back to the point of finding enjoyment even when it wasn't what you set out to look for.
Right, exactly. So how did you make the decision to go from the scope to opening? Did you say this is something I can diagnose it through the scope, but I can't fix it through the scope? Is it something that you were better off fixation wise doing open?
Excuse me. Yeah, some might have skipped the scope, to be honest with you. In fact, I would say most might have skipped the scope. For me, the scope was beneficial in the sense that it gave me a better sense of both what had been sheared and also the injury site, and finally looking for other injuries. So it gave me a kind of 360 view of the anterior elbow, posterior elbow, and I was hoping that I could bring the piece was anteriorly. And I was hoping I could bring it back posteriorly and then approach the elbow through an anconeus split and keep it really simple. Didn't turn out to be that simple, and I had to take down the lateral ligament complex to get exposure, to get the repair, and on my way out, I obviously repaired the lateral complex. Um, yeah, so I think the scope was potentially a step that could have been skipped, but this was a big open procedure in the end.
Now, is this a different fracture or injury morphology than the capitellar shear fractures that Dr. Wall had a run of a couple of years ago? I know that she was describing a particular approach to get there. Or...
Yeah, I would say this is similar to, but younger patient than, and far more subtle. Those fractures that she was addressing had a clear major bony component, and there was never subtlety. This was just harder to pick up, and therefore, took a little longer. But
How'd you
same
fix it?
idea.
How'd you fix it?
I use three bioabsorbable headless compression screws. And the trick there is that you are then balancing fixing this fragment, which you have to do, obviously, with the growth plates and stability, and then obviously early motion because an elbow and elbows get stiff.
How long does it take for those bioabsorbable compression screws to absorb?
Yeah, I don't know if there's a difference in adults and kids, but I think we're looking at 12 plus months. I always worry a little, I don't use a ton of bioabsorbable screws. I always worry a little bit about a joint reaction to that. But our sports colleagues use them regularly and seem to be happy with them.
And are these typically transphyseal, or are they all epiphyseal, or are they?
I hope to avoid the physis. In this particular, we don't need to go into the details. It was a 16 millimeter length was the shortest length. I thought about cutting it, but I didn't think I'd get the fixation. So I just went ahead and put it in. And I think it tickled the physis and hopefully won't bother it.
I don't know the last time I said the word epiphysis. It's been a very long time.
Well, say it a couple times in a row. Let's see how you do with that.
One of my friends was a teed sports person up in New York, and I remember him going on and on about all epiphyseal ACLs, and I was like, not my thing at all.
Yeah, it does add another level of challenge sometimes. But that's what makes it fun.
Exactly. So before we jump into this advocacy topic, I did want to note that The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Checkpoint now offers a specialized notepad to assist in documenting Guardian stimulator device settings during surgical procedures such as decompression.
You have to explain to me what that means. I have lots of notepads, but not one related to Checkpoint. But if you're interested in receiving a threshold stimulation notepad to facilitate accurate tracking of stimulation settings, contact your local Checkpoint sales representative or email marketing@checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery. What does this mean?
I actually know what this is because I was at a meeting with Checkpoint recently. I think it was back in August. And I was like, remember those notepads you had where you could like record, like what if you stimulate at certain settings, what kind of response you get? And one of my and anybody who's used a nerve stimulator in general, whether it's Checkpoint, Medtronic, whatever other ones you use, the anesthesia setup, knows that we don't have a great way of documenting how we use the device and what kind of responses we get, and that's incredibly valuable information. So then they said, "Oh yeah, we have this notepad that says like this is a setting, this is a pulse duration, the pulse width, etc. You should record this." So it's there. It's an interesting thing. I think that I wish it'd be great if it was sterilizable and could be written down by the surgeon intra-op, which I think is very challenging because otherwise you're just rattling off a bunch of numbers to a circulator who is not terribly interested in recording this information for you. So we've actually at our lab we've taken this to the next level and created a more detailed version of it in REDCap that we're starting to use for all of our nerve transfer and nerve reconstruction cases.
Excellent. I don't know that I have a need for a notepad. Maybe I do. Maybe I just don't know it. But hey,
You exactly. It's the thing you never knew you needed.
until
That's
you,
marketing, baby. That's marketing.
well, as you know, I'm in business school and I'm learning about this kind of stuff. And it is the Steve Jobs quote about the public doesn't know they need something until you show them that they need it. Maybe this is that.
I think it is. So why don't we jump into the email? We have an email from Jon Lundy, who is a private practice hand surgeon in Austin. So John emailed us at this point, probably about a month or so ago, saying that he retired from the military about a year ago and is been in private practice and has noted some issues. And there is a lack of a formal professional group in Texas, and he has founded the Texas Hand Society with his colleagues. Their vision is to improve access to care by working uh, to get access to appropriate and high quality hand surgery care for all patients in Texas. And then you need an organization to collaborate and coordinate all of that of the surgeons with the healthcare providers, health systems, payers, and policymakers. And to his recollection, he has about 55 members so far, and they're looking to expand recruitment efforts and emailed us. So anybody who is a hand surgeon practicing in Texas, if you wouldn't mind reaching out to Jon Lundy, his email address we will put in the show notes. I won't shout it out on the air, but that way you can reach out to him. He's in Austin, and that actually, not only do we want to applaud John for his efforts for gathering his colleagues, but also talk a bit about advocacy and the role it might play in the practice of hand surgery and hand therapy.
Yeah, kudos to John. Sounds like an important step and off to a good start. I'm not sure how many hand surgeons are in the state of Texas or how many surgeons who also perform hand surgery are in the state of Texas, but there is power in numbers, and that's the point. And you know a great deal about advocacy. I know how important it is, and recognize that many of us, sometimes myself included, don't. Um, think enough about it. So first, maybe tell me how you think about the term advocacy and what it means to most of us.
I think the advocacy term is a pretty broad one. I mean, I think it's thinking about how to, advocate for oneself and for a group of like-minded individuals in not necessarily negotiations, but discussions with other people who control power, essentially. Whether that's, because I know that you have had a lot of efforts in terms of our group practice in advocating with payers, with insurance companies. We can go through maybe the example of the needle aponeurotomy. But then there's also advocacy at, political level. You can have advocacy at a local level in terms of advocating for your group of practitioners, surgeons, therapists with a hospital system, et cetera. So it really is rallying the troops in a way where you are trying to make people know what you're feeling, how things might be able to change in a mutually beneficial, ideally, way to improve delivery of care.
Thank you. I think that was well said. We sometimes we can have tunnel vision and believe, and perhaps in a perfect world, this is how it would be, that if I just take really good care of my patients, everything else will work out. As I've gotten more cynical with age, that's just not true. And taking care of the patients the right way is great, but there are so many different factors to our ability to do that. And we could go down a million different tangents why private practice is struggling. There's just so many things that affect our ability to practice that tunnel vision is not helpful for, I guess I would say, bigger success.
Yeah, no, the put your head down and take care of the patient mentality is probably the best and worst thing about being a doctor. And, I think that those who are on the other side, those who control the purse strings and the power, love that about us because then they can then take advantage of us. And then when they need the care that they want, they get what they want. So and I think this extends beyond American healthcare. You see advocacy playing a big role, especially in the UK with the NHS, and honestly with residencies around the world, and the question about unionization. So not only in other in parts of Europe, but also here in the States, you're starting to see residencies at different hospital systems unionize, and that's clearly another advocacy piece. But yeah, the best part about what we do is getting to take care of people. And I don't think we pay enough attention, get the high level view until you've been doing it long enough where you don't have to worry about the patient, not worry about, but you can think more than just about the patient in front of you. Um, because it's so hard to do, to do what we do, and to take care of people that it's easy to just miss the rest of what's going on around you.
Right. And I think a lot of us think that our societies, which is one reason we all do and should belong to various societies, do this, I would say, quote unquote, for us. Um, but they do it in different ways. And simplistic, maybe we should talk a little bit about that, and then we could go back to some kind of boots on the ground examples. But the Hand Society does work um, around coding and assuring that there is appropriate identification of RVUs for procedural codes. But the hand study, I would not say lobbies like the AAOS for our orthopedic surgeons out there. Is that accurate?
Yeah, I think that's accurate. I think because of what most hand surgeons do is there are a ton of unique advocacy issues for hand surgeons that are different from what plastic surgeons, orthopedic surgeons, general surgeons, physicians in general are feeling. And most of you who are listening know that to become a hand surgeon, at least in the US, you either train in orthopedics, in plastic surgery, or general surgery. By far, it's usually orthopedics or plastics. Um, and at least for orthopedics, there is an incredibly powerful political arm in Washington. It is actually, if not the biggest, it's the second biggest relative to the American Medical Association Political Action Organization, PAC, committee in DC. I think it's pretty incredible the machine that they have. So just for context, when I was a resident, I was very much interested in health policy. At this time, the Washington Health Policy Fellowship still existed at the American Academy of Orthopedic Surgeons. And I was fortunate enough to do that policy fellowship, in one of its last years of existence. And it was a really neat experience because my co policy fellow, Eric Mackney, who is a resident at Columbia, now is an attending in Detroit, doing sports. He and I would go down to DC. We were both in New York, so we would just take the train down, and we would go lobby on the Hill, which was super, super interesting to see, what the American Academy of Orthopedic Surgery PAC was doing, what issues they organized around participating in the health policy efforts that they had with big, uh, they call it the National Orthopedic Leadership Conference, but it's when they get everybody in from the state orthopedic societies, and a bunch of orthopedic surgeons and related disciplines hit the Hill, and you meet with congressional leaders, people that represent your district, and you honestly, it gets down to telling stories. Nobody really cares about data initially. The good thing about a lot of physicians is that we have a lot of stories to tell if you really think about it, because you have patients and people can relate to patients. And I think one of the examples that we did recently when I went to the Hill as part of the Hand Society group is that, and this is a few years ago now, but it's prior authorization, and something that seems relatively mundane, but trying to make sure that you don't get bogged down in prior authorization before a procedure or an MRI or something like that, and explaining to somebody in Congress who has no idea of what your day-to-day life is, trying to find a compelling story about why this is important for them to pay attention to make sure that, they, include details in whatever upcoming legislative package that make sure that they can't have too much process before you get prior authorization, for example.
Yeah, it's funny. Every sentence or two, my brain would go in a different direction because you said so much, all really important stuff.
That's you saying, keep it concise next time,
No,
Chris.
no, I don't think so. It was all good. One thing that came to mind was that is the challenge of Medicare Advantage plans, which I think is actually probably a pretty good example of why we need to advocate for ourselves. In the United States, Medicare is the big government payer. Medicare Advantage was proposed as a way to help control cost for Medicare patients. And in reality, it has not worked out that way. It has become a really challenging insurance payers, and every major commercial insurance has a Medicare Advantage plan. And actually, that is where commercial insurance makes their money in 2024. And it is really, really challenging. And it is setting up roadblocks, and they do little things like they want to attract Medicare Advantage plans. They want to attract healthier patients because it's essentially capitation. And by attracting healthier patients, they have to pay out less. By setting up roadblocks for prior authorization or declining to pay for inpatient rehab, they make more money. So one way to do that, as a good example, is they offer free gym plans. So if you join Medicare Advantage for so-and-so firm, you get a free gym plan. Well, who's going to be interested in going to the gym? The younger, healthier, I put younger in quotes, Medicare Advantage. So anyways, I'm off a little bit on a tangent, but that's one of the
You
things.
are. You definitely are off on a tangent. The way I'll bring it back is that if you're an insurance company in states, and you want to make more money, you sign more people up who are going to pay to be part of your service, and then you pay less, and you give out less money in terms of services. So if they can make it as hard as possible to pay for services, the more money they make. So and this is something that is common throughout medicine. It's not only hand surgery. Definitely specialties that are procedure based, like surgeons, they get affected more just because the way that the system has been set up, whether you like it or not in the US, is that proceduralists tend to get paid more, and proceduralists depend more on making sure that they get paid for the procedures. And it's not a zero-sum game in terms of the money that's available. Everything in the States is based around what Medicare, which, as you mentioned, is the largest government payer, pays for a certain procedure. Now, insurance companies and work comp, they may pay a certain percentage higher, but everything, the bar is set by Medicare or by CMS. And, if they value the procedure codes more, they're going to value the primary care, diagnosis E&M codes less, and vice versa. So it's this constant battle. They've set us up to fight each other for the same amount of money. The pie is not growing, so to say, which is why it is really important to have a big pack behind you, which is what orthopedic surgeons and by virtue of that, hand surgeons benefit from a lot.
Yeah, I mean, the pie is massive. Almost 20% of our GDP goes to, medical care, which is incredible and so much higher than every other country. True or false? The American Hospital Association is not our friend.
Oh, they're not our friend at all. Not at all. I mean, I don't know what you were looking for with that, but they also get a piece of the pie on this, and the more that they pay the doctors, the less they have to pay the hospitals. And just this is a broad overgeneralization, but I feel like a lot of people talk about how Medicaid, which is the government-based insurance in the U.S. for those under a certain income level, it was the crux of expanding care under Obamacare back in 2008, is I guess when that effort started. Um, the more Medicaid is traditionally not a great payer for physicians. You get a certain fraction of what you would get paid for Medicare. It's probably the same thing for therapists too. But the hospitals do very well with Medicaid because it is a state-based program, and especially at some state-based hospitals, like university-based hospitals that are public universities, they have carve-outs, which they will get a much better rate if you get care at a certain university hospital in our state. That hospital will get paid a lot more as opposed to if you got care at a non government based hospital like ours. So anyway, there's a lot of money in healthcare in the U.S. Like you mentioned, it's encroaching on 20% of our gross domestic product. And this is actually a pretty timely discussion. I think healthcare has not been part of the conversation as much this year in the U.S. election, but we are recording 2 days before the United States general election, which is crazy to think of. And all of these uh, healthcare issues really matter. And whether you lean one way or the other politically, I think that the single-minded focus on protecting the interests of physicians, providers, et cetera, at the PAC tends to make it relatively politically agnostic. I had a hard time so I was actually chair of the Hand Society's Government Affairs Committee. And my political views personally don't necessarily align a lot with the AAOS. And so while the ASSH is a subspecialty society, typically falls under the AAOS for a lot of things. And I differed a lot with the academy, and I struggle with that. And I know that some of my predecessors and successors on that committee also do. But at the end of the day, they support the candidates and candidates at local and state races that are going to help orthopedics. So I have a hard time, I struggle with that. But at the end of the day, they really are trying to protect the interests of the healthcare professional.
Yeah, the election talk is super interesting because you're right. Remarkably, it's not been a primary discussion point, but there are huge implications for the results of the election here in the U.S. with which candidate prevails. And the concept of single issue voters and orthopedic surgeons only voting for the candidate that may support orthopedic surgeon priorities is really an interesting one. But not for this discussion. What about the AMA, the ultimate? advocacy group for physicians. Share a few thoughts, and I have a few as well, given I interacted a lot with the AMA in preparation for an AOA, American Orthopedic Association session this past summer.
Yes, I'm a little bit out of my depth on the AMA. I mean, I know of the AMA, and I think a lot of us, at least in, schooling and training, participated in the AMA. I know that we have a loyal podcast listener, Andy Gurman, who is also active on the listserv. And amazingly, this is an incredible shout out to Andy. He was president of the AMA as a hand surgeon not that long ago, probably about 10 to 12 years ago, I think. Really amazing accomplishment. So Andy, if you want to give us some thoughts about the AMA, please feel free to email us. But it is, I think, a different organization in terms of the priorities. It's got to serve the entire House of Medicine. And typically, it is nice when the House of Medicine aligns on issues and everybody can get behind, and the AMA is the face of things. But there are some issues within medicine where, the specialists and the proceduralists will differ from the primary care oriented groups. And I think, the AMA is tasked for better or worse, are trying to unite the House of Medicine because, people from outside of medicine don't understand that we have all these different factions within us. They view us at sometimes as a monolith.
Yeah, you're right. And Andy, obviously, we're proud of his leadership of the AMA and advocacy in general. A non-hand surgeon, Michael Sook, who I don't know if you know him or
Mhm.
not. I do not know him well, but he has the best collection of initials after his name because I'm looking at it. I looked him up, but I'm going
Are
to
you
be
jealous,
a
Chuck? Because I know you're adding more initials.
I'm a little jealous. He is an MD, JD, MPH, and MBA. That is impressive. But he's also, for the point of this conversation, the current chair of the board of trustees of the AMA. So incredibly important position, which, again, they are the ultimate advocacy committee for all physicians and some of our listeners, many of our listeners are in the therapy world. And sometimes these advocacy efforts actually, can be head-to-head clashes, such as autonomy and independence in caring for patients and the like. And ultimately, one of the AMA's primary goals is to encourage teamwork, but always have the physician as the leader of the team.
Yeah, I mean, to put it differently, it's scope of practice. You see, I remember when I was a resident, the AMA battling with the podiatry organization about scope of practice for podiatrists in the state of New York at that point. And I don't know if they have gotten that success, but trying to do things like knee arthroscopy as a podiatrist and just, encroaching on things that are typically viewed as the purview of the orthopedic surgeon. I think the hand therapy group, at least in Missouri, scored a recent win, which was nice for them that they can now get direct access evaluations. So if you call up, you typically how it's worked in the past is that you would need a referral and a prescription from somebody like me or Chuck to go see a hand therapist before your insurance company would authorize that. But now I think they do have direct access for, I think it's PT and OT, to see a therapist to at least get worked up and diagnosed, which I think is a change. And I'm not saying it's for better or worse. I think in a lot of ways it is a beneficial thing to help access for patients. Those are the kinds of tensions that you can see with scope of practice and between professional organizations.
Yeah, well said. And then to be very specific, it's scope of practice and scope of practice creep, as it's been labeled by the AMA. I think I like the content of our conversation. I wonder if we could have organized it a little better, but I think some of the points we made are, hopefully many of the points we made are important. And my takeaways from this conversation is number one, I have become better about supporting organizations that advocate for physicians and surgeons and hand surgeons. And I think we all should really think hard about that because practicing in a bubble or practicing, in a very, stay in your lane way is just not the way to do it in 2024.
Right. And I think there are a couple of issues I could, ideas I could bring to the forefront here that would maybe draw some attention to those of you that are practicing or in training and don't quite get it. But I mean, for example, like in Missouri, and Medicaid is a state-based program, as we mentioned earlier, and you have a patient with Medicaid, and you want to do therapy after their distal radius fracture. Guess what? physical therapy isn't covered after surgery, amazingly, after by the state of Missouri for Medicaid. So this is, relevant for us as hand surgeons, but also like say, for example, you want to do a total knee replacement on somebody and you need them to get access to therapy. If you know that they're not going to be able to go to the therapist after surgery, are you still going to do the total knee replacement? So it becomes this cycle that's very vicious and very puts the patient at a disadvantage. So, if we were to look at efforts to rally and advocate at the state level to improve access to Medicaid or access to therapy for Medicaid patients. That'd be one example where a practicing surgeon could really provide some compelling stories. Also, a practicing therapist, we could work together on something like that. And then, people paid more attention to politics when it involves the economy and their pocketbook, and you can see that's one of the leading issues in the current U.S. election. And as a surgeon, if you are paid a certain amount for a certain procedure for years and years and years, and then it just starts to go down, like the devaluing of the total hip and knee replacements over the last 2 decades. And you can see that the American Academy of Hip and Knee Surgeons has a huge advocacy arm that has developed even outside of the Academy's pack because they really want to protect the value of those codes so that they can continue to be paid at least the same as what they've gotten paid in the past, as opposed to getting cut 2 to 3 to 5%, if not more, every year. So people pay attention, unfortunately, or better or worse, when it affects their pocketbooks too. And I think that maybe you could just close us with that little snippet about, advocating for our surgeon group with doing needle aponeurotomies.
Yeah, it's a great it's a great way to close, even though we could go on, I think, for a really long time. Um, I was told that a needle aponeurotomy procedure that I had done in the office was not going to be reimbursed, despite having, pre-authorization or pre-approval, I guess. I'm not sure of the terminology for this particular insurer. And I said, well, why is that? Which led to conversations in our group at the Department of Orthopedic Surgery at Washington University and ultimately with the medical director for this particular insurance company. And we had a great discussion, and he was a physician, and he recognized the cost savings to the insurer, to society, the benefits to the patient. All of those things were true if we did the needle procedure in the office. But he said, based on the insurer's interpretation of Medicare and CMS rules and regulations, they would no longer be paying for the needle procedure in the office. He agreed that it was nonsensical, but he felt he could not do anything about it. And that's been 6 months. And so for that particular insurer, we no longer do needle procedures in the office, which is a shame.
Which is crazy because they probably would pay for it if you did it in the OR.
100% they wouldn't. I've done some, and what we do is they're just wide awake in the operating room, and we're adding, many multiples of cost.
Right, because now you've
Um,
got that. Not only you're paying. So before you would pay Chuck Goldfarb the physician fee. I don't even know if we were charging a facility fee as a
nope.
university for that. Now you're paying Chuck Goldfarb the physician fee, probably the same. You're paying the hospital for their time and through the facility fee. You're adding this cost on, which, depending on your insurance plan, does affect the out of pocket for the patient, which is absolutely insane with the given the caveats and the acknowledgments that you made before.
Yeah, it's really crazy. And for the younger listeners, just to be very clear, if a surgeon may charge $5 for a procedure, you can guarantee yourself that the hospital is charging 4 to 5 times multiple of that. And so the money is in the hospital system, maybe for good reason, but to add that unnecessary cost to a procedure like this is crazy. So we we'll continue to fight on this because it's the right thing to do in every respect.
At least you're not adding the anesthetist into that, because that's another professional fee and more facility fees. Crazy. So I think the point today of a discussion, which is timely given the at least the political calendar in the U.S., is that you have to be part of the advocacy efforts, and whether that's doing great things like Jon is doing with his organization, participating in your local organizations, contributing money to the political action committees. If you're if you're not at the table, you're on the menu, is what they like to say in DC. So if you're not advocating for yourself, you're the one that's going to get eaten up. So please support those efforts in whichever way you feel most appropriate. Everybody's a little bit different with how they want to engage with that kind of stuff.
Absolutely. fun to talk about this stuff, and it'll be interesting by the time this podcast drops. We will have at least, hopefully, we will have an identification of the next president, which will affect all of us
Oh
specifically
yes. Oh
in
yes, it will.
in the healthcare realm. All right, have a good day.
You too.